You can go ahead.
All right. So, okay. Thank you very much. Thank you everybody for attending our first Uganda ICU Registry in critical care conference. It's an honor for us and a privilege as well for us to have you, but also for us to have gotten here in this time. I really thank all the previous speakers for some really empowering presentations, and I really pray that when we have the next one, we shall really have built and made a lot of progress. So when I was asked to talk about data to decision, I'm sure these guys know the journey we've made in trying to get the government to recognize the importance of critical care. It hasn't been easy, and I will try to share some of the things and some lessons learned from this journey. So, yes, I'm from the Department of Anaesthesia. I'm colleagues to many of you, and I think my only conflict of interest with regards to this is we started this journey writing this grant with the leads, and we're very lucky to get this grant from the Wellcome Trust, and with Adam and Cornell leading this project. And I really want to thank all the participating sites for their trust in this process, and I can guarantee you that good things are coming because of the evidence that we're generating that will help care of our patients. So, of course, in some of these things, whenever you come with anything that may impact policy, it's always going to be the why. Many times we talk about publishing so much work and papers that don't really translate into anything. They may help with evidence building, but over the years when I've interacted with 3 ministries of health in Africa, one common theme is that they view things differently from the way we view. I'll give you an example. A lot of the studies that we have done, Adam presented ASIOS data, which is very compelling. And then there's the study by Atumanya that talked about the need for improving critical care capacity, and a lot of other ICU studies. When you go sit and present this to someone in the ministry, it takes a while for them to actually translate that into action, for example, into policy. And learning that over the last, maybe I started this journey dealing with ministry people, every turn, just getting to sit on their side and understand how to convince them that this is a very important thing. A lot of people, advocacy in itself is a clinical skill. Many people don't get that. When you're advocating with your patient for, let's say, a procedure or therapy or diagnosis or, a predisposition to care, that in itself, being able to convince them is a skill in e-learning. And that's what separates. You have 2 very good doctors, but one doctor will be more effective because they have the advocacy as a skill. And this translates even to the policymakers as well. Being able to understand the other person and see their point of view, and also being humble enough to appreciate the fact that, sometimes you not have all your cards, and sometimes you need to know when to go and when not to, when to ask for a letter, when not to, and so on and so forth. And like I've mentioned, policy is a long game. I said it's been 10 years, and interestingly, like some of you know, the first paper I published, the precursor to the Atumanya paper it got me into trouble, and I had to go to the minister and explain myself. I won't go into very long details, and then I had to tell them, what we meant by an ICU bed is exactly this, and yet the people are saying we have 2,000 ICU beds in the country, and this is 2013. Because it appeared in the monitor, and then I was being accused of being opposition and so on and so forth. So when you're trying to, we need to know that we're not going to get results immediately. If we do, we're lucky. And I think the reason why critical care blew up was because of COVID. It was a very, very inconvenient tool that helped us convince or the ministry suddenly realized, okay, this is something that we have to tackle. And it might have been the one thing that we were lacking in our armamentarium in terms of convincing them for the need for critical care. So it's for everybody in this room. It doesn't matter where you come from. Critical illness is something that happens, like now we've seen from the ASIOS data, it happens anywhere, in your home, in the clinic, in the hospital, in the community, and we need to move that. I'll talk about that a lot later, to move that paradigm forward. So this, sorry about that, this is basically a village. It is the Kisoro District Community Critical Care Project. And, you know, nobody thinks about, everybody thinks, oh, this is it has to be in an ICU. And we, because of this, we had to come and say, you know what, we can do this at the lowest level possible. This is an ongoing project that the association is doing. But so far, it's gaining a lot more traction because we are practically showing that the lowest level of CADA, if you can see, of course, we have now here, there's an anesthesiologist, Dr. Daphne, who had gone to provide support supervision for that. But, you know, then you have a medical officer, and then you have an anesthetic officer, a bachelor's anesthetic officer, and a biomedical engineering, and an ICU nurse learning, you know, on one side you have a ventilator, which we then learned, you know, you can't apply in this setting because the skills that you need are a little more advanced for that. But this is something that was cheap, the ministry saw as cost effective, and somehow has gotten sneaked into from a futuristic, maybe after 2028, coming to policy where every district has some sort of HDU, ICU type scenario. Now, I just threw that in as to open your minds and as to what the possibilities are. I'm hoping by now that I don't need to explain to you what the registry is. But just very quickly, as you know, this data is just a summary of where we are, and more is still happening because we are still recruiting more sites. And the whole idea is to generate, you know, longitudinal critical care evidence that can help us provide a proper denominator for policy claims. Because many times people want to ask, so, you know, do you have data right now? And if we do isolated studies, aggregating them becomes very difficult. But if you have one big pool, you can actually query the system to give you something that focuses on one area. It might be we are asking for, like one of the students is doing malaria, another one is doing sepsis, the other one is doing pediatrics, and we're very able to query the database to quickly generate something to know, to show what the burden of disease is and help us with policy. And the other, of course, for me, I would love that, you know, everybody in the room, for starters, becomes an advocate for evidence-based care and also becomes an investigator. And one of the things we've learned, obviously, over time is that it's much more cost-effective to have a registry that can ask the right questions rather than going back every other time to design a new study, and then you have to ask for funding for it, which may or may not come, and so on and so forth. So the other thing also we need to realize the advantage is that, you know, by having a registry, the data to decision pipeline is much quicker than an isolated study. We just completed the ARISE trial, which we started in 2023. And we're very lucky that we had some immediate results based on the questions that we asked. That is it feasible for a medical officer to provide high flow oxygen therapy in a place where there is no intensive care? So we answered that question, and we did a dissemination workshop, and then in Ginger, and then the ministry immediately plugged high flow oxygen therapy into its armamentarium or an inventory at the national medical stores. So that was one win. But in many respects, I feel like that was a fluke, because you know, we were lucky in the sense that we were able to get all the right people in the room. But it also comes back to the point that we included the Ministry of Health people from the get-go in some of the aspects of trial design as well. But what commonly happens is that the first two steps, we gather data and we generate evidence. These are things we are good at, but for the next 3 up to 5, this is where things get these things get difficult. And this is where we really need to start interrogating ways and of how to get this over the line. And I'll show you from my little experience how. So one, the advantages, first of all, is that one, you have very, very easily defensible denominators, because you have, like I've said, you have population rates that single trials cannot deliver, and yet, in a very short period of time, able to aggregate this evidence right, on the go. It's becomes like a living document. When we were doing the COVID recommendation studies we had what we call a living document. So whether it was a platform trial, every result that came, we just kept building. And if you go to the BMJ, the living guidelines for COVID treatment, we're just plugging in every trial result that came out, and kept updating the treatment recommendations. The other thing is that obviously you can see trends, and even with those trends, you're able to actually identify factors that are associated with the changes in the trends. It might be seasonal variations, like in climate. It could be, politics, funding issues, because our budget cycles, how they go, and so on and so forth. And of course, it's very applicable to our daily lived world. And then, of course, the advantage of the registry, I like the registry because it helps, it recruits every person who is involved in care of the patient, from administrators all the way down to even families. And many of you have experienced, in the talks, you've talked about how the units have learned I had a talk from Nakasero Hospital where they were saying the benefits of having the registry has helped them be more vigilant in terms of data collection and management. And what it does is it builds ownership. Whereas this starts as an initial project of 2, 3, 4 individuals, it grows. I mean, I'll be away tomorrow, for one reason or the other, but it becomes its own living ecosystem. And this is one strong suite of this. So Dr. Adam has already talked about this. We had an informal conversation a long time ago after the publication of the ASIOS of the study, and he's already talked about this. And we use this to convince the ministry, Dr. Olaro, to reframe critical care from a specialty service. Like I said, critical illness can happen at any level, to a point prevalence problem. And that can be, in other words, it just happens just like that. A patient comes in for a C-section, gets infected, gets organ dysfunction. That's critical illness. And that patient, we need to have a discussion around how do we deal with that, not from a specialty perspective, there has to be an ICU where this patient gets managed. But, one, the ability to make a diagnosis that this patient has organ dysfunction. My area of research is organ dysfunction. And then what do we do about it there, whether we have an ICU or not? Because we also learned that early recognition is probably the number one thing that makes a difference. The World Health Organization, after the summit, actually there's now one going on in Geneva, recognized that emergency and essential critical care is a problem, and they have a resolution of that effect. The colleagues from Tanzania, Tim Becker and Otto, have done a very good job in pronouncing this. And it also part of the reframing is that critical care can happen anywhere along the referral pathway. So this is just some background data, talking about data and how we use it to make compelling cases. This is work that we did a long time ago, around 2021, 2022. And we used this data to show that in patients who had, critical illness by our definition, and use of 7 and above, that needed either high dependency or intensive care service, were 10 times more likely to die than patients who did not need it. So, and this was, ASIOS already showed that as well. We then picked from the Kisoro cohort study. It's about 1,300 patients between 2022 and 2025. Like Dr. Cornelius said, part of my PhD work, I had of course, oxygen therapy
ARDS was my primary thing, but we'd also designed a sub-study that had some genomics and so on, but also looking at acute illness in one setting nationally, but also, and we chose Kisoro district. Now, when we were working with the ministry, I also happened to be, and this is part of the lessons. You leverage yourself, you come across, you're picked as an expert, but you need to look at what other opportunities, what other things within your armamentarium of your specialty you can solve when you are engaging with Ministry of Health people. So we did, when we were doing the National Medical Oxygen Scale-Up Plan, I was asked to support the ministry as a technical advisor. And some of you might have attended. We looked at 85 or so facilities, and we picked up some information that essentially guided the national oxygen strategy. And this basically talks about how data informs policy and informs decision. We were lucky to be part of the Lancet Commission on medical oxygen. And at the point, we were able to actually do some costing studies that enabled the provision of pulse oximeters and oxygen concentrators and manifold systems. We are currently doing a project where we are piping 16 hospitals around the country, and this is manifold in every ward, whether it's pediatric, surgical. We're piping into the ward. You have all the ports, so outside you have the manifold system, and some of this is based off of the work we did in Kisoro. But just being around and having conversations, and you do work on one side and you say, hey, what do you think of this data? This is what we found. These are the improvements, and it will cost you a tenth of, your budget. And people like things like that. So this is just a lesson where data was already in place, and so we didn't have to again go back to generate more evidence or look for funding to generate more evidence. It might not have been registry data, but I'm just explaining in effect, we had the data, and that was a registry, a small registry in its own, of how we could actually be used to impact policy and translation. And the difference was that we were very quick at making a difference, because it was also the politics of the day. Now, this was this when we look at this, we used the Atumanya study to put it upon the government that in order for us to be able to contend with the next pandemic that needs organ support, we would need X number of beds. So we did things like estimating, doing oxygen needs estimations and so on and so forth, that we had also plucked out of the National Oxygen Scale-Up Plan strategy to enable us do this. Now, it was very easy to use ASIO denominators, but we also had discussions with some of the initial data that we got from the district cohort for this. And because the ministry, luckily enough, over time after COVID, had plugged intensive care into a priority area, we were able, one, to increase capacity for human resource recruitment. So we also separated, job titles, job descriptions. And big thing for us was we're able to plug in specific roles for critical care nurses, intensivists. As much as anesthesiologists are the baseline cadre that can operate a general ICU, but we also put in a framework in which you can actually have super specialized training in intensive care. And that's a role that's recognized and is now in the Health Service Commission job structure. This just gives you a sense of what we think the total number of public ICUs will be by the end of this year. And as you know, construction is happening. We started with Arua, Hoima, and Kabale, and the others are also in the pipeline. Of course, it's a whole thing with regards to funding. But once you show evidence and then these things get plugged into budgetary frameworks, we can't control that side because that's not our space. They have to find the money for it. But at least it's now a policy document that every regional referral should have a 10-bed ICU, the 20-bed HDU with these resources and so on and so forth. And all these hospitals have oxygen plants and the piping that can enable adequate oxygen provision. Then, of course, we also looked at, again, using, so looking at, okay, we can't ventilate patients, but can we offer a higher level of oxygen hypoxemia management, basically non-invasive, but advanced respiratory strategies? And we showed that, with high flow oxygen, we can do something. It doesn't save everybody, but for many people where that is the last line of defense, we showed a significant reduction in negative outcomes. And we just also tried to see, after training, more generic way, and just observed and showed that there was a high mortality in patients who did not receive oxygen at all. We're not trying to control it. It wasn't a trial, it was observational. And so then we knew that, okay, including high flow oxygen and next iteration of Uganda's the essential and critical care package, based on, subject to adequate oxygen and so on and so forth, was a cost-effective intervention. And of course, we did a study for that. So we looked at some key interventions that if we closed the oxygen treatment gap, if we deployed high flow oxygen, for example, and if we did early ward-based sepsis care, as you can see, we found that, for example, almost half of the patients were facing catastrophic healthcare expenditures. 60% of the costs were non-medical, food, accommodation, transport, airtime, and which is very hard to justify some of these things in terms of these are things that drain people. And then, of course, there's job losses, because someone who is not at work is losing income and is actually spending. And that's what led to this 44.6%. So per critical illness episode, the median, household cost was about 35.6%. But then when you look at the numbers in terms of closing the oxygen treatment gap, was $15 per death averted. And this data is there. We have a paper that is under consideration somewhere, so it will come out at some point. But the whole point is that by this addressing things that in a very cost-effective manner using data, this is now what the ministry is now considering, because from the get-go, there were part and parcel of planning for this work. So I might have given you some clues on how to engage our colleagues at the Ministry of Health. One, you need to understand these are our colleagues. They have had our lived experience. They usually have come from very, very low resource places as well. So you already know that they have an understanding. But as a subject matter expert, you know a lot more about them in that regard, in your regard, but you don't have that their lived, or you may not have had their lived experience. And so typically what you do is just, some of them, because some of them will be our former classmates in medical school, who might have gone to the same school of medicine. Your social skills are very important. We all have titles, but at the end of the day, we're all human beings. So if you're passionate about this, and I believe we're all here because we're passionate about this, go and talk to them, meet them in the office initially, formally, send an email, and then say, can we have a conversation about this, over a cup of coffee? And then some of them support Arsenal, and they might need a lot of, they have been a very long suffering fan. So you take them to an Arsenal game, watch together, and hope that Arsenal wins, even if you're a Man U fan, because then they may be more amenable to a conversation. But that's a side job. But make sure that you're constantly talking to them. They need to see that you're passionate about this, because they also need a lot of help when it comes to data acquisition, evidence, and so on, because their roles are very lonely, by the way. They're understaffed usually. They are overwhelmed with a lot of work from other projects and other things. They have to meet funders and so on. So you know that you're going to have to take on a significant part of their work. It helps from a strategic perspective that you write a one-pager about what you want to do, because they don't have all the time to read a 300-page document. Remember that we are not we might be researchers, clinicians, scientists. They are not. They are more policy administrators. And then time, budget cycles. Start conversations early, and by the time you've built rapport and you built a document, you just keep asking them, when is the technical working group? Because these things go in stages in the ministry. And then, of course, coalitions are important. I like, when you work with, critical illness is an intersection of one, all the other disciplines, two, hospital administrators, directors, and so on and so forth. So it's best whenever you do something, you get a grant, get everybody in the same room. Don't isolate it to doctors only, nurses only. No, everyone has something to contribute to this. And no, like I said, it's a long game. Always keep them in touch. Create a WhatsApp group and keep telling them about what's going on elsewhere. Just keep in the space, because sometimes when a funding opportunity comes, you're there, you're the first person that they will think about. And then you have to, every language that you write for anything that you do, you have to see what's in their, in their own language frameworks. You see all these things, Vision 2040, SDG 3, UHC, ECC is something we might know because it's an our forte, but it's not what you want. It's what fits into the global political language. And then, like I said, you do the bulk of the work. You write the policy documents. I literally wrote the National Medical Scale-up Plan for Oxygen document with like 2-3 other people. And these are from the Oxygen Task Force and the funding partner. And then these guys who took them to a workshop, they read through, they approved, they brought their policy-oriented, even things like semantics. Then we did that, and they appreciated that as well. Now, what has worked? I think I've shared quite a bit. But what is likely to work for us is if we can get one of us to be in the technical working groups, not just as an external expert, co-authoring policy documents with ministry staff, even just manuscripts. Like if you notice, a lot of the papers that are pushed out regarding Uganda level things have guys from the ministry, whether it's the PS, the DG, TWG guys, and so on and so forth, because they have contributed, and it's good for the ministry to have ownership of this work. It's good for their CVs, but it's also good to show that the country is working together with academia to solve these problems. And then, of course, again, leveraging global frameworks. I've already discussed that. And then what I've recently learned is the cost of any care, because that's a very, very important thing. How much do you save the country by this intervention? For example, I think mechanical ventilators, it's very hard to defend if we don't meet other targets in terms of human resource, availability of consumables, and so on. So on my side, I'll be very careful about going for those very expensive assets, because as you can tell from COVID, all regional referral hospitals receive mechanical ventilators, dialysis equipment, and they're not working. So that's a negative return on investment. And then you keep talking the same thing, keep preaching, so that, if at the ministry where they know Arthur is Mr. ICU, Mr. Oxygen, or whatever it is, we are not just the only one. Then it's Adam, then it's Cornelius, then it's and so on and so forth. Like, we become a movement. And I really like that there's a lot of people here. I've listened to the pitches by the investigators. They might think that they're doing this for their own dissertations, but these things are seeds. So the advantage with having access to the registry is that any of you can, in the room, as long as you meet the minimum, requirements, can actually be an investigator. You can approach one of us as the seniors we talk through an idea, and then you go through the steps to, get ethical approval and so on, so that you can actually build your portfolio without spending too much money in terms of building a CV as a researcher. But every researcher, clinician, is an advocate, and that's one thing that we need to remember. So what you shouldn't do, and these are hard lessons I've learned, don't publish a paper and think that policy will follow just like that. You think that you've done your part, and then, no. Guys don't read journals. Don't do a one-off workshop like we do this and we have ministry present, and then we don't do this again next year. That's yeah, it's just, people will thank you, and then other things will take over. I learned not to use very jargon heavy words, hypoxemic respiratory failure. Or if I do, I'm also at great pains to explain what those are. But that's also by repetitive engagements. And then having clinician-only groups without working closely with the ministry would take us nowhere. And then, of course, not understanding the budget framework, is a hard thing. Can't start asking for blood gas machines at the moment when we are not doing very well on the care side in terms of oxygen therapy, or when there may be cost-effective alternatives. And then if you have data, now, policy public engagement has actually become a very big deal. Dr. Kabatoro just did a study in Kusoro where she interviewed, not just in Kusoro, even in Kampala, where she interviewed survivors of critical illness. And some of the things they said were quite compelling. I cannot say anything yet until she's published the work, but leaving that information out is unhelpful, because you end up doing the wrong things without patient advocacy. So I've already discussed about the global frameworks that give local advocacy cover. And I have the 5 Ps that I like to use. So you have a package. What is the problem, the rate, the cost of the ask, and then the price timeline. You have the person, your partner in the ministry, who you work with and engage with regularly. These guys now, a lot of them are personal friends. Some of them will hang out somewhere. Some have visited their homes. Have visited mine. It's now first name basis. I keep telling them, don't call me professor, because that is not the point. Then the other one is the fora. Technical working groups are very, very important places to be, but to get there, so on. Don't give up. Cornell likes calling me the eternal optimist, but the lesson I've learned in that is that at some point something gives. I mean, we are here now having a registry conference, but would never have thought about this if we had given up. This small, just keeping the hope alive somehow. Something happens. I do not know what will happen in the next 5 years, but I think and I believe it will be good. Plus, what other things can we do in the meantime if there's something we are caring about? And then partnerships. This I cannot overstate enough. So now we're data collectors. What I really want is for everybody now to look at the data as a source of information that helps us drive improvement in care for our patients. So you're moving from a data steward to a policy translator, okay? And I think that is something that the key thing in my message would be, we collect data, but what does it mean, and how can it help? In anesthesia, for example, we're hearing of patients who are dying on the operation table because so on and so forth. But how are we translating that into, that is data as well. What are we doing about this? This is just, you don't need to answer, but these are things that I know many of us in the association are continually working with the ministry to deal with. So the 7 habits is 1, learn to write a 1-page policy brief. You can do this as practice. You can do this, especially for those who have actually presented their studies, Kawesa, Namubiru, and so on. Then identify and engage one partner at the ministry that is within the domain that you're trying to investigate, maternal child health on one side, and so on and so forth. And then, speak on one non-clinical forum, build civil society partnership, parent-patient associations. I know we don't have, what we have is SERHAD, but it's very, it's more of a civil society, but it's okay. It's a starting place. And then, track one indicator that you think that is linked to one very explicit policy commitment, if we can get one, and report on it annually, because we'll have the data that we are collecting as a registry will show. And again, publish one mortality cost of inaction translational paper, because that is something that you can always have as part of your armamentarium to show, if we do not do this, this is the direct outcome. And then as we are going, as you grow and as we're going, for those of us who are a little bit advanced, try to mentor one colleague specifically in advocacy. In other words, wherever, if we're going to the ministry to meet someone, we get some gundi jangu tugende, then we go and they sit in the meeting and they see how we engage these people.
Arthur?
This is what I'm envisioning
Arthur?
in a few years'
Can
time,
you hear me?
5 years' time, you know, that we'll have essential and emergency critical care and so on. We shall have
Can you hear?
doubled our ICU density, even though our, our population rate is, fertility rate is high, but just hoping that we can match and surpass that where it's double. We have oxygen continuity at all levels at least 95%. And we national mortality reports are now registry led. I know the Ministry of Health has got under DHIS, Adam is working with them to include a critical care component. But at least for, hardcore critical care, to keep the faith and the standard as has been shown. And have at least 100 people who come through the registry and are able to synthesize and sit in one room and everybody is helping drive this thing and ensure that 1 to 4 are active.
Arthur, can you hear
So,
me?
Arthur, yes,
Can you hear me?
yes, I can hear you.
Yes. I'm going to give you 2 minutes to wind up.
Yeah, I'm almost done.
All right.
So again, what every member in this registry can do, look at all this. You identify one policy hook, find an MOH counterpart, draft that 1-pager. It doesn't have to be pure or anything. It's just putting your thoughts and seeing how it should do. Join, we'll create a WhatsApp group, join it, and then pick one of the 7 habits and start it between now and September. And then see yourself as the advocate, not the next person, not me and so on, but make sure that it's you. Every patient in this registry is an argument, waiting to be made. Is a compelling case for improvement of their own care and